Hello everybody. I am grateful for the invitation from Steph and Claire. I want to thank them for allowing me to speak tonight to you. Sadly I can't be with you because I have another appointment, but I thought I would give you a little talk that you can get your teeth into. And I'm going to talk to you about cardiac defibrillation, which of course is a scary concept. The experience I have of this is quite lengthy and quite detailed because I spent 16 years working as a volunteer paramedic in Belgium with the Belgian Red Cross, and I would work one night a week. For many years it was 12 hours, and then it was reduced to 8 hours, and that was what I used to do. I was one of a team of 2 paramedics which would man the ambulance, and we'd go out from the hospital in Saint-Gilles, and we'd cover the emergency services in that area over 3 or 4 communes. Anyway, part of my training, which lasted for a couple of years in fact, part of my training was in cardiac defibrillation, because of course one of the main missions which you receive as an ambulance paramedic is to deal with heart attacks and all sorts of problems with the heart. And I arrived actually in the Belgian emergency services at about the same time as they were receiving their first semi-automatic defibrillators, what are called AEDs now. You may have seen these devices. They're much more common now than they were 20 years ago when I started. You see them in swimming pools, in gymnasia, in hotels, any public place basically, because the latest algorithms which are used by the best semi-automatic defibrillators, AEDs being automated external defibrillator, are now more than capable of diagnosing the arrhythmia in the heart, the problems in the heart, and deciding whether they can be defibrillated. And then all the operator has to do is actually apply the 2 electrodes to the right clavicle and the left side of the thorax, which basically crosses the electrical axis of the heart. So that's a fairly easy thing to do. Then you turn the machine on, and the machine will decide by itself whether the problem with the heart which you're trying to deal with can be solved or can be treated by defibrillation. Let's back up a bit now. Let's talk about the physiology of the heart to give you an idea of how it all works. It's actually very simple, which is why I was able to understand it. And I'll try and explain to you in a simple fashion if I can, but I'm not very good at that. Right, so basically you've got 4 chambers in the heart. You've got the 2 atria, the right and left atria, which are the top 2 chambers of the heart. And then you've got the ventricles, which are the lower 2 chambers of the heart. My shorthand way of thinking about it was that the atria do the minor work and the ventricles do the major work. That's more or less how it works out. I'll explain in a second. And the atria and the ventricles are joined by, connected as it were, by 2 valves, the mitral valve and the tricuspid valve. You may have heard of how people having their heart valves replaced because these valves often tend to leak, which means they don't close properly. And when that happens, of course, the pumping action of the heart is much less efficient. Anyway, let's back up again to the physiology of the heart. What happens is that the oxygen-poor blood, which has been used by the cells of the body, will come into the right atrium, and it will be pumped out of the right atrium into the right ventricle. And from there, the right ventricle will pump this oxygen-poor, what they call vitiated blood, which is no use to the body because it has no oxygen to carry. It will pump this blood to the lungs. And then as the blood is circulated around the lungs, it will take in oxygen from the air, become oxygen rich. And then from the lungs, this blood will go back into the left atrium, the left top chamber. And from the left atrium, it is then pumped through the valve into the left ventricle. And from the left ventricle, it will leave that part of the heart, in fact, leave the heart and go out all around the body to feed the cells, which obviously require glucose, oxygen, and various other chemicals such as magnesium and potassium to function. And that's basically how the body works. That's how the body converts air into oxygenated blood. Now, the heart is a pump, as I'm sure you've heard before. It's a muscle which is a pump. And the way it works is it has an electrical network which is a part of the heart wall, the muscle around the heart. And the electrical network will give a signal to the atria and to the ventricles to enable them to pump, to close and open, to contract and, what's the word, the opposite, and dilate in due time to enable the heart to actually effectively become a pump. Now, when there is a problem with the electrical network of the heart, or when there is what's called a myocardial infarction, then part of the heart muscle will die, or in the case of electrical malfunction, the electrical signal will not be given in a proper way, and the heart no longer becomes a working pump. It will still contract and dilate, but it won't do it in a way that is actually efficient. It won't do it in a unified way, which means that the muscle is no longer working as an effective pump. That's when you get fibrillation. Now, what most people don't know is that, you've seen it on TV and in films no doubt, when you have somebody who has a heart attack, or an MI as they call it in the medical field, a myocardial infarction, it's quite rare that you have the problem which can be solved by defibrillation, because there are only two aberrant heart rhythms that can be defibrillated, and they are ventricular fibrillation, which is where the ventricles, the lower chambers of the heart, I'll try and show you, they are basically pulsing like that, and they're not actually working in an effective fashion, which means that they aren't pumping. That's one aberrant rhythm that can be defibrillated. The other one is ventricular tachycardia. Now, ventricular tachycardia, which you may have heard of, VT in the profession, is when the heart beats. It is effectively beating, but it's beating very fast. Now, generally speaking, most protocols will say that you can defibrillate a heart which is in ventricular tachycardia if the tachycardia is above around 180 beats per minute. Because if you think about it, that's 3 beats per second, 3 dilations and compressions of the heart per second, which means there isn't physically time for the chambers to be filled with blood, which of course means that it can't be useful as a blood pump. And generally speaking, if you've got ventricular tachycardia, which is around above 180, 200, it varies from person to person, there is no basic pulse because the heart is not effectively pumping the blood. So if you're in the presence of a pulseless ventricular tachycardia, then generally speaking you can defibrillate. But in my experience, and I must have probably dealt with over the years, who knows how many, maybe 300 heart attacks. And speaking off the top of my head without actually having the statistics to hand, I would say that only 1 in 5 maybe was actually suffering from a problem that could be defibrillated. And then again, once you attach the defibrillator and you defibrillate, if that's possible, there's still no guarantee, of course, that the heart's going to restart effectively. If the heart's been damaged, for example, by an infarction, a dying of the part of the muscle, then very often the heart is not going to recover. Or if someone's been attacked, they've been stabbed, they've been shot, there the heart obviously is physically damaged, and it doesn't matter how many times you defibrillate, the heart is still not going to return to its pumping function. So when you attach the defibrillator, you always hope, of course, that you're going to be in the presence of an aberrant rhythm which you can sort out using the defibrillator. And even then, you have to get all these things in context, because even then, even if you do have one of the 20% of problems which can be defibrillated, and then it actually works, the defibrillation actually gives the heart a restart, and the heart becomes a functioning pump again. And that, again, is far from the case every time you deal with it. Then, depending on how fast you got there and how long the heart has been failing to pump blood, it may be too late anyway. If you don't get there within, it depends on a lot of factors like temperature and that sort of thing, but if you don't get there within 3 or 4 minutes, that's pretty much the maximum. After that, the brain will have died, which means you can actually possibly restore circulation, but the person will be a vegetable And so that also obviously is not exactly a happy outcome either. I do apologise for my cold. So that's a basic rundown. Now, speaking on a more personal basis, and I'll talk for another couple of minutes if I may, because you can always cut the speech into two if you need to. It was a very exciting time to be involved with the rollout of the semi-automatic defibrillators, because you could use them without having the same amount of training as a doctor would have. Because not only does the external automated defibrillator decide by itself whether it wants to administer an electrical shock to the heart, it will decide how much current to use. And that's something which, prior to that, the arrival of these machines, a doctor had to decide for himself. Now, normally you will start with 200 joules of current and then move up after, say, 3 shocks to 360 joules. Again, this all varies as a function of the weight of the person, whether it's a child or an adult, that sort of thing. What is different from what you see in the films is that, generally speaking, whenever anyone's attached to a defibrillator in the films, it always works and the person recovers and they get up and start walking around. But that is not actually the case, generally speaking. Generally speaking, it won't actually restore the heart to functioning. And in that case, what you have to do is actually apply cardiopulmonary resuscitation, CPR. So that's the protocol. So either if you can't use the defibrillator because the heart is malfunctioning in a way that cannot be solved by a defibrillator, or if you have used a defibrillator and it doesn't work, then you can always resort to cardiopulmonary resuscitation, CPR, which is a mixture, no doubt, as you understand, of heart compressions and I'm not sure what it calls in English, so I did all my training in French, insufflation, when you breathe into the person's lungs. You reinflate the lungs. So you do these things together, and you do them for, well, basically as long as you can. It's quite tiring, until the doctor decides that there's no point in continuing, and the doctor will sign off and say the person is dead, or you will keep trying, and maybe it'll work. And then you can always try, possibly, defibrillating again. But that's the protocol. And you can't just jump in and apply the defibrillator and assume it's going to work, because it's only in a minority of cases that a defibrillator is the answer to the problem. Another thing which we pioneered in the Belgian Red Cross, which I was again quite proud to be part of, was what they call, what's the word? What is it called again? It's been years since I did it. It's compression and decompression, which is actually active and positive. So you have rather than using your hands on the rib cage to compress the heart, which is what you see in CPR, that relies on the elasticity of the rib cage to be able, once you've compressed the heart, for the rib cage to rebound so you can recompress the heart. And in old people, where the bones are brittle, that elasticity is not there so much. So what you need to do in that case, and this was again a pioneering technique, is apply a device which will compress the heart, which is standard, and then it will actually suck the chest outwards and actively decompress it. So that way you aren't relying on the rib cage to do the work for you. Now these machines, the active compression and decompression machines, are actually basically a big sucker. It's rather like the sort of sucker which you use to clear your sink or your toilet, and you stick it on the thorax, and you grab hold of it, and you go up and down like that, and it's active compression, decompression. It's actually very tiring, because we were part of the initial trial in Belgium for this active compression decompression technique of CPR, and our own blood pressure when we were doing this would rise sometimes to 200, which is actually very high. And so it was an extremely tiring technique. I think actually after our trials, it wasn't very widely adopted, partly on those grounds. Another reason why the active compression and decompression system was not brilliant was that because you weren't actually physically contacting the chest of the patient yourself, you couldn't tell exactly how much pressure you were applying. And so what would happen was that you'd break a lot of people's ribs, especially older people, because the ribs are fragile. And sometimes if you break several ribs together, several contiguous ribs, you end up with a problem called a flail chest. Now, a flail chest means you've got a whole section of the rib cage that is not functioning. because it's not joined together, and that means that the muscles of the heart, muscles of the thorax and the lungs are not able to work with the rib cage because the rib cage is no longer basically present. And that was one of the reasons why I think that technique was not very widely adopted afterwards. I'll give it another couple of minutes because I say if it's too long and boring, you can always cut it in two or throw the whole thing away. Anyway, there are a few other rhythms of the heart which is perhaps useful to talk about. The basic normal way in which a heart functions electrically is called a sinus rhythm. And a sinus rhythm is what you see on all the TV shows and T-shirts and things. It goes up and down, and it's that standard thing which you see, squiggle, which in the medical profession is divided into P, Q, R, S, T. Those are the 5 stages of a standard sinus heart rhythm, which is a normal heart rhythm. Then you can have something which is called a cardiac tamponade. Now, a cardiac tamponade is not a good thing to have because what happens is that within the wall of the heart, the muscle around the heart, you have bleeding, and the blood will infuse between the parts of the heart muscle around the heart wall, and it will stop the heart functioning as a pump again because the pressure of that blood inside the heart wall is compressing the 4 chambers, which means they can't work properly. And that happens very often if you get a stab wound, somebody who's been attacked with a knife, which I had lots of dealings with. And a cardiac tamponade is a difficult thing. You have to drain the blood out to enable the heart to actually function again, to relieve the pressure. You've got a thing called the agonal rhythm. The agonal rhythm is basically what happens as the heart is about to die. So the heart is maybe damaged, it starts to fibrillate, and then nothing is done. It will go into the agonal rhythm, which may last, several minutes, possibly less than that, possibly 30 seconds. Then the heart will die, and there's no more electrical activity, which is what they call flatlining. And flatlining, as you know, is English slang for all sorts of things. For example, you might say, I was in the booth yesterday for 45 minutes, and it was a really fast speech. My brain flatlined. So it's the standard flat line which you see on the electrocardiogram in a hospital or on a TV show in a film, and that means there's no more electrical activity, and that's called asystole. So asystole, there are no more systoles, because a systole is the word used for the entire procedure whereby the heart compresses and dilates. That is asystole, and if you have no systoles, you have asystole. Voila. Anything else I wanted to talk about? I've made a few notes here. There's lots more to say, but maybe for next time. Anyway, it's very, very gratifying to be able to use a defibrillator, which is not that difficult to use, quite frankly, and to actually save somebody's life. Because that's one of the reasons I became a paramedic, and it's one of the reasons I learned CPR, which is the basic technique for life support, and then moved on to the ability to be able to use a defibrillator, because it's a huge high to be able to actually come across somebody who is dying or possibly even dead, and sometimes you can actually bring that person back to life. Obviously you can't, but the life returns to the body. It's a bit more depressing if you think about the number of people who actually end up going into hospital having been what they call recovered at the scene, and then they'll be hospitalised, and the number of people who actually then leave hospital as normal functioning human beings is again reduced. So you weed out percentages all the way through, which means the actual overall success rate of the entire cardiac defibrillation, taking in charge in a hospital environment, recovering, restoring to life, etc., is reasonably complicated because you lose people all the way through. But the human heart is a wonderful and amazing machine if you think about it. You probably shouldn't think about it too much because it makes you depressed. It makes you paranoid if you start thinking about your heart pumping away all these years. Anyway, that's a bit of my experience. I appreciate it was probably a bit technical, but I would have provided Steph and Claire with a small glossary by the time you actually end up interpreting this. I hope you learned something, and I hope I was not speaking too disgustingly fast. I know I tend to do that. Take care. Bye-bye.